and sometimes even for the patient's life, is rather doubtful. The second problem, second disorder of the optic nerve is papillary edema. Papillary edema is defined as swelling of the optic nerve head secondary to raised intracranial pressure. Raised intracranial pressure may therefore be caused by the following mechanisms. Space-occupying lesions, including intracranial hemorrhage, brain tumors, abscesses of the brain, blockage of the ventricular system by congenital or acquired problems, obstruction of cerebrospinal fluid as the result of meningitis or cerebral trauma, brain trauma. Benign intracranial hypertension may cause papillary edema, the so-called pseudo tumor cerebri. Severe hypertension, I mean not the intracranial, but general arterial hypertension also may cause such a complication. And hypersecretion of cerebrospinal fluid by hyaloid plexus tumor is very rare condition. It was described several times only, but it's also one of the mechanisms of increased intracranial pressure. And finally, papillary edema. Here you see the pictures of the patient with papillary edema, I mean ophthalmoscopic picture, and the visual field. The precise pathogenesis of papillary edema is not entirely understood, but it seems clear that intra-axonal swelling with accumulation of mitochondria and not extracellular extravasation of fluid is the principal early mechanism resulting from raised intraneural pressure. This results in swelling of prelaminar nerve axons, and early papillary edema is simply the result of oxoplasmatic stasis at the nerve disc. These vascular changes, venous congestion, hemorrhage, are secondary. In chronic papillary edema, in addition to swollen axons, there is extracellular accumulation of fluid edema and ischemia. Papillary edema is nearly always bilateral. Patients usually give history of recurrent attacks of transient blurred vision. In such symptoms, in such complaints, you should be very attentive to this disorder. Visual acuity in majority of patients remains normal for a long duration. It is affected only in the end stages when atrophic changes set in. Symptoms of associated raised intracranial pressure may be present: headache, nausea, vomiting. Visual field changes. Enlargement of the blind spot. Here you see both areas of blind spot increased in size. With fully developed papillary edema. Concentric contraction of peripheral fields becomes apparent as atrophy sets in, only in advanced stages. What about the ophthalmoscopic picture? Let's have a look at the elevation of the disc above the plane of retina. It looks here even without a 3D image. Disc becomes markedly hyperemic, and blurring of the margin is present all around. Veins, they're a bit darker than arteries here, and here you see veins, become tortuous and engorged. Soft exudates and superficial hemorrhages may be seen near the disc. Soft exudates in form of yellowish, whitish, grayish patches with the not very sharp borders, and hemorrhages in form of flame-shaped hemorrhages on the optic nerve disc. For example, here you see one of these hemorrhage. Papilledema should be differentiated from pseudopapilledema due to high hypermetropia and papillitis, which we have already discussed. In case of papillitis, you remember the onset is acute with a sudden loss of vision. In this case, it's a long period of time with a normal visual functions, even in case of such a severe ophthalmoscopic changes. In case of pseudopapilledema, no signs of pathology, no loss of visual functions, except the refractive disorder, high hypermetropia. Papilledema indicates raised intracranial pressure and a neurologic emergency. It's not an ophthalmologic, but neurologic problem, basic problem. The patient requires immediate admission to a hospital, to a neurosurgical department. Papilledema usually develops quickly, appearing with 1 to 5 days of raised intracranial pressure. And recovery from fully developed papilledema is rather slow. It takes about 6 to 8 weeks to subside after the intracranial pressure is normalized usually by neurosurgery, removing of the brain tumor or decompression of the areas of the optic disc and so on. Optic nerve atrophy is the result of chronic papilledema. It is characterized by grayish-white discoloration and pallor of the disc due to atrophy of the neurons and associated gliosis. Visual acuity is severely impaired. Here you see different types of papilledema with elevation of the optic nerve disc, with the with this soft exudates, yellowish, with the mild hemorrhages. So it's a very, very severe problem, and it's a risk factor risk for the patient's life, because due to the presence of very serious disorders of the brain. About the optic atrophy. It refers to degeneration of the optic nerve, which occurs as an end result of any pathological process that damage axons in the anterior visual system from retinal ganglion cells to the lateral geniculate body. 3 major etiological types are recognized. Primary optic atrophy refers to the simple degeneration of the nerve fibers. Secondary optic atrophy occurs following any pathological process which produces optic neuritis or papilledema. And hereditary optic atrophy, the so-called Leber's atrophy. Common causes of primary optic atrophy are multiple sclerosis, intracranial tumors, pressing directly on the anterior visual pathway, traumatic changes. Consecutive optic atrophy is the result of diffuse chororetinitis, retinal pigmentary dystrophies, occlusion of central retinal artery. I hope you remember these disorders from one of our previous lectures. Glaucoma and vascular disorders may also cause optic nerve atrophy. And other types, very specific types, and in during our last lecture devoted to glaucoma, we'll discuss more thoroughly the specific changes of the optic nerve in case of glaucoma. Clinical features of optic atrophy. Well, first of all, it's a loss of vision. A loss of vision may be of sudden or gradual onset, depending upon the cause of optic atrophy, and partial or total, depending upon degree of atrophy. A visual field loss will vary with the distribution of the fibers that have been damaged. They are central scotomas. As I said before, it's defects inside the visual field. Different contractions of peripheral fields and hemianopic defects. Ophthalmoscopic features. In case of primary optic atrophy, optic disc is pale. Its edges, margins, are sharply outlined. Retinal vessels are usually very narrow, and it looks dirty white, sometimes grayish. Its edges are not so sharply defined as in primary optic atrophy. In case of secondary atrophy, secondary optic nerve atrophy is characterized by changes in color of the optic disc. So this is the difference between primary and secondary optic atrophy. Of course, treatment is rather difficult, and prognosis for the patients for recovery of visual functions is doubtful. In most of cases of patients with optic nerve atrophy, we just try to stop the progress of the process, but we can't recover visual acuity or visual field or any other disorders and visual function changes. The main groups of drugs are vitamins, vasodilators. Physiotherapy play an important role in treatment of optic nerve atrophy, but in some cases it's doubtful. I mean, it's under discussion and not supported by all the ophthalmologists. Among the types of physiotherapy, the most frequently used are electromagnetic stimulation of the optic nerve, infrared laser stimulation of the optic nerve. You know that they can stimulate the exchange processes, they can increase the blood nourishment, decrease the edema in case of its presence, and has also anti-inflammatory effect. So the use of optic nerve atrophy, the use of physiotherapy can be useful in some cases in etiological types of optic nerve atrophy. So that's all about the disease of the optic nerve. And if you have questions about this part of the topic, let's discuss it.
Sir, in methyl alcohol amblyopia, is it always bilateral or can it be unilateral also?
In most of cases, this condition is bilateral.
Okay, thank you.
Because it's a systemic damage, so it's usually bilateral. And do you know what is the, maybe from neurology, from toxicology, what is the drug which we use in case of methyl alcohol intoxication? Ethyl alcohol. We use ethyl alcohol to stop the process of methyl alcohol intoxication in form of intravitreous injections and so on. Any other questions? No questions. Okay, let's have a small break about 5-7 minutes, and then we'll continue with the disease of the orbit.
Okay, so
So let's continue with the disease of the orbit. So you know what this means, orbit. This is a space between the orbital walls and the contents of the orbit, not only the eyeball, but additionally orbital fat and blood vessels, nerves of the orbit, and extraocular muscle, which turn the eyeball in different directions. Let's start with the orbital cellulitis, or another name, orbital phlegmon. It is suppurative inflammation of the fat and cellular tissues of the orbit. The following are the main etiological types. Sinus-related is caused by extension of infection from paranasal sinuses. So in a lot of cases of inflammatory disorders of the orbit, of the other parts of the eyeball, uval tract, for example, we need the additional consultation of our friends, otorhinolaryngologists, because sometimes the main problem with the paranasal sinuses, main etiological problem, and we can treat rather effectively, rather aggressively, the inflammation of the orbit or the inflammation of the parts of the eyeball, but without the sanation, without the successful treatment of the paranasal sinuses inflammation, the result will be doubtful. So X-ray examination, special endoscopic examination can help to determine the problem in form of sinusitis, and additional treatment, sometimes even surgery of otorhinolaryngologists can help us to solve the eye problems and orbital problems. From adjacent structures, next etiological types, when we can see inflammation as a result of complication of other inflammatory disorders like dacryocystitis, inflammation of the lacrimal sac, chronic or acute, midfacial infection, or even dental infection. So when you have a patient with orbital cellulitis, you have to exclude all these etiological causes, because if you'll find any changes, you have to treat such patients together with the other specialists. Well, post-traumatic is one of the most common cause of orbital cellulitis. Most commonly develops within first 2-3 days, 48-72 hours of an injury that penetrates the orbital septum. In some cases, the typical clinical features may be masked by associated laceration or hematoma. In case of traumas, in all the cases, we can see a lot of great surprises. So one of such surprises is orbital cellulitis. Post-surgical may complicate retinal detachment surgery, strabismus surgery, dacryocysterinostomy, and orbital surgery. The main causative microorganisms are Streptococcus, Staphylococcus, and Haemophilus influenza. So not very specific. You can find them on the skin. You can find them even in the conjunctival sac in normal condition. And if they, through any post-traumatic penetration or by other ways, come into the orbit, into the orbital fat, they can cause very, very severe inflammation. What are the symptoms of orbital cellulitis? Symptoms include rapid onset of headache, fever, pain in the eye, around the eye, behind the eye, in the eyelids, in the half of the head, and so on and so forth. Even nausea and vomiting, in some cases even prostration due to general intoxication. Patients feels severe pain, which is increased by movements of the eye or pressure. So palpation of the eye is very painful in this case. Eyelids, as you see in these photos of patients with the orbital cellulitis, eyelids are swollen, erythematous, means hyperemic, warm, and tender to palpation. So local, you can find here all the signs of inflammation, which I hope you remember from the pathophysiology. Rubor tumor, color, dolor, funcția lese. So local hypothermia is one of the symptoms. A marked hemosis of conjunctiva. Hemosis means edema of the conjunctiva, so severe that even if the patient will close the palpebral fissure, you'll see this edematous conjunctiva through the eyelids out of the conjunctival sac. The eye is proptosed axially, I mean in the anteroposterior direction. The most frequently proptosis is lateral, to the left or to the right, and downwards. Ocular movements are restricted, it's clear, because of the edema and inflammation behind the eyeball, and painful. In advanced cases, visual acuity may be diminished due to the compression by the edematous tissues of the optic nerve. Potential complications are intracranial complications like meningitis involving in the process brain coats, brain abscess, and cavernous sinus thrombosis. All these complications are the high risk of death of the patient. So the orbital cellulitis is a very severe, very serious disorder, which should be treated like an emergency case in the special departments. Then subperiorbital abscess. It is relatively rare in sinus-related orbital cellulitis, but may occur in post-traumatic and post-operative cases. And ocular complications like keratopathy, means pathological changes of different kind of the cornea, raised intraocular pressure, a sort of ophthalmohypertension, occlusion of the central retinal artery or central retinal vein due to the compression, and optic neuritis, which has been discussed a bit earlier. How to treat? Orbital cellulitis is an emergency requiring hospital admission. Intensive antibiotic treatment, parenteral or topical broad-spectrum therapy with cephalosporins, with aminoglycosides, sulfonamides, penicillium sometimes. It depends on the type of microorganism, the stage of the process, duration of the process, and so on. Analgesics and anti-inflammatory drugs. Pain is one of the main symptoms, pain in the eye, painful ocular movements. So to decrease this pain, to relieve this pain and to increase the quality of patient's life in a moment, it's necessary to use analgesics. Anti-inflammatory drugs is clear, it's a huge severe inflammation, so we have to decrease the inflammatory symptoms. To prevent severe edema and compression of the orbital structures like optic nerve, blood vessels, it's possible to use osmotherapy, 40% glucose solution intravenously. Vitamins like neuroprotectors to prevent the severe damage of the optic nerve. Surgical treatment. It should be considered in case of unresponsiveness to antibiotics, in case of decreased vision, presence of an orbital or subperiosteal abscess, general intoxication, negative dynamics of the general condition and with the local status of the patient. A free incision should be made into the abscess when it points under the skin or conjunctiva. If you see the pus point in this area, you can make a cut through the conjunctiva, sometimes through the skin, depending on the localization of this pus point, and then remove the pus. In most cases, it is necessary to drain both the orbit and the infected paranasal sinuses. So after removing the pus, you should wash it with antiseptic, antibiotic solutions, then put the drainage to prevent secondary deposition of pus in this area. And you have to treat the comorbidity, such problems as paranasal sinuses infection and other disorders of the surrounded tissues, organs, and so on. Other types of acute orbital inflammations are orbital osteoperiosteitis and tendonitis. Very briefly about them. Orbital periostitis is the inflammation of the periorbita. It may involve the surrounding bones, producing orbital osteoperiosteitis. It may result from injuries or as an extension of infection from the surrounded structures, similar to orbital cellulitis. Clinical picture may be in two forms. Anterior orbital periostitis. It involves the orbital margin and is characterized by severe pain, tenderness, and swelling of the inflamed area. Subperiosteal abscess, when formed, frequently bursts on the skin surface. And posterior periostitis is characterized by deep-seated orbital pain. Exophthalmos means protrusion of the eyeball anteriorly, slight limitation of ocular movements. Sometimes there may be anesthesia of the skin of eyelids and of the cornea. And tendonitis. Inflammation of the Tenon's capsule, usually unilateral, and it is characterized by pain, increasing urine eye movement, mild exophthalmos, and mild hemosis and lithedema. The main etiological factors are inflammation of the eye structures, injuries of Tenon's capsule, and postoperative tendonitis. As you see, there are no photos because clinically, patient looks, in case of tendonitis, orbital osteoperiosteitis, and orbital cellulitis, looks the same. All the signs of inflammation, usually the same complaints like restriction of ocular movement, pain during the ocular movement, and so on and so forth. General symptoms also, the severity of the process and the presence of the general symptoms depends on the stage of the process. Computer tomography, magnetic resonance tomography, ultrasound examination of the surrounded tissues can help us to determine the type of inflammation. So general orbital cellulitis or local orbital osteoperiosteitis or just tendinitis. The principles of treatment of inflammatory diseases of the orbit are the same. Intensive antibiotic therapy. It may be topical or systemic. Sometimes we combine these types of therapy. Of course, if you use different antibiotics, use antibiotics of different groups. If one of the antibiotics is, for example, cephalosporinum group, take another one from the macrolides or aminoglycosides and so on. Topically, we can use drugs in form of drops, but it's maybe it's not so frequently because they're more effective to use subconjunctival and retrobulbar injections. Then, to relieve the pain and to increase the quality of patient's life in a moment, we can use analgesics and anti-inflammatory drugs, if necessary. Surgical drainage. Very effective in case of pus formation and usually associated with the immediate relief in local and systemic status of the patient. Physiotherapeutical treatment possible, but not in